वो clade 2 है actually. Clade 2 is West African clade, which is actually mild. इसमें जो mortality is as 1%. और जो clade 1 है जो कि world around हो रही है उसकी जो mortality is up to 10%. तो I think अभी तक तो इंडिया की गुड न्यूज है कि हम लोग जो केसेस आए हैं वो clade 2 के हैं जो कि mild है. So I think this is. So I would like to invite our. चलिए प्रदीप जी आपको एक मिनट करना पड़ेगा निश्चय उनको बुला नीचे हो. So thank you Dr. Rajiv sir for chairing the session, and I invite you to facilitate our both the speakers on the stage. Rajiv sir. Can you take a photograph? Because ये आपके उसमें आगे से न्यूज़ Mr. Nisha, I request Dr. Kewal sir to join to facilitate our chairperson Dr. Mansur. Yes. So now we'll start the second session, and to chair the session we have Dr. Chattopadhyay sir, our senior most member, and Dr. Makkar to chair this session. And I invite our speaker, Dr. Anup Bachchan, and we talked to Dr. Bachchan that she said that I have not presented any case for a while. So you speak very well. I think it will be a asset for us to listen to you. And he's actually, take up the questions on our EDP WhatsApp, and he has a good sense of, clinical, knowledge. And that actually we all need. We all need, theory, but sometimes when the patient comes in a difficult situation, we all stuck up that what to do, right? So I think to take to this practical aspect of the clinical learning, so he's a very interesting case, and we'll take the opinion of the house that if this case comes to you, right, what you would have done or not, right? So I request Nandu to take up the session, and we are quite pleased to welcome Dr. Tanya also. Dr. Tanya is the radiologist, and she's working as in the CDC, and I think we were missing this radiologist part. So I think in addition of Tanya to the group, I think most of the things would be getting better. She is Tanya Garg now.
I had to change my name back, but Tanya Sehgal Garg, as you all know, but as professionally Tanya Sehgal.
Yeah. Welcome to the TP, right? So Dr. Anand, all yours.
Thank you, sir. And I assume this is the second time that I have been convinced, or rather browbeaten, to present a case at EDPA. And so before I start, I just want to give a brief disclaimer. So we've all been presented, and we are used to hearing cases in which all the cases are pretty well thought out, and the patient and both the doctor happen to be in a very comfortable environment in which every investigation under the sun could be done easily. What we as physicians face in our day-to-day life is something entirely different. We do not have the luxury of having all investigations. Sometimes have the luxury of having no investigations whatsoever. Sometimes have to base our treatment on investigations done previously. And sometimes we have to pick up from where treatment was started by some other physician, some other colleague of ours. As I said, the world is not ideal. So what I'm going to present now is an unideal case, to be very honest. As I said, it's a disclaimer. And I'll be putting in front of the audience, all seniors of mine, as to what they might or might not have done differently up to the point that we stand right now. The patient's treatment, which I'm presenting, is currently continuing, and what they might or might not do differently in the days or weeks or months to come. Right. So even the computer is kind of unidentified right now. So, right. So the way I have the thing is quite unconventional. And as Dr. Pankaj Chaudhary pointed out, this is one of the scenarios in which a close cooperation with your radiologist was of help. As I said, many of our physicians also do not have the luxury of having a radiologist that we can call up at any time. Most of the patients, when they come to us in our clinics with their CTs or with their X-rays or with their ultrasounds, many times we would love to discuss it with the radiologist as to what do they think. Sometimes the staff does not write the patient's history. Sometimes the patient out of the blue gives a different history when he reaches the CT scan center. And then the CT report differs from what you were expecting. In this case, well, I was fortunate enough to have the luxury of calling up Dr. Tanya as and when required, and we'll see how that affected the case as the slides progress. Right. So this patient we're talking about, he was a young active male of 28 years of age. He came to me with complaints of left lower axillary pain for the past 3 months, and the pain was persistent and progressive, and it was preceded by a history of fall approximately a week before the symptoms started. That was at one of his cousin's wedding. The pain was aggravated on coughing and sneezing. He also had cough for the same for around 60 plus days, which was again progressive, non-productive, with no significant diurnal variation. Was aggravated on positional changes and was also aggravated while sleeping, especially for the past few weeks. And that was especially on the right lateral position. He also had fever for the past 45 days, and it had a variation and was increased in the evenings. He also had complaints of exertional dyspnea for the past 1 week, which again was progressive. On physical examination, the vitals about they had tachycardia and fever. And on physical examination, on auscultation, the breath sounds were reduced on the left side, and all of the examinations were within normal limits. The slide is not completely visible. Okay, coming on to the history. The history, past history was non-significant. There was no history of any prior surgical interventions. There was no significant family history, and there was no history of any addictions. He was a photographer by profession, unmarried, and with no history of any multiple or commercial sexual partners, and no history of any tattoos either. Lab investigations, pretty normal. He had leukocytosis, along with a slightly elevated ESR, neutrophilic leukocytosis, and the LFT, KFT, TSH were normal. And all the investigations were from the previous physicians that he came to me with. And the urine investigation is also normal. This was the first X-ray that the patient got done way back in March. As we proceed, the patient presented to us in June. This was the X-ray which was done almost immediately after he had his first onset of symptoms by an outside physician. As is clearly visible on the X-ray, he has not just blunting, he has an opacity in the left hemithorax. And on naked vision, at first sight, all of us would say this is nothing but a pleural effusion. Do we all agree with that? I guess there is no controversy in that this is a case of a pleural effusion. Anyways, now the patient was
right. Is that a flash of the light or is it the itself?
this? Yeah. This would be flash, sir. An ideal case at the very beginning. Right. So we'll get on to the treatment history of this patient. As I mentioned, he was initially treated by a local practitioner, after which he presented to Hegdewar Hospital on the 21st of March. And there also he was again managed conservatively and was planned for a diagnostic pleural tap. However, the pleural tap which was attempted was dry. He was then planned for an ultrasound guided tap, which again was dry. He was then referred to GTB hospital with a provisional diagnosis of a left side pleural effusion, oblique mass, oblique loculated pleural effusion. However, the patient did not go to GTB hospital. He continued to see various other local practitioners and he took multiple courses of oral antibiotics as well as NSAIDs. He did not improve anyhow, not for a prolonged period of time. And he continued to have fever off and on, along with cough and chest pain. And eventually he also had dyspnea before he presented to us. In the middle of this all, he was then referred by a local practitioner to Safdarjung Hospital. This was in the 3rd week of May. So he's already been symptomatic for 2 months now. Now, just at Safdarjung Hospital, he was advised for a CT scan. And the CT chest, I'll just be showing the films as well. Say he has a lateral X-ray too. That was again done at Safdarjung. They'll be coming when I show the serial X-rays. This was a CT scan that was done at Safdarjung on the very first day of representation. There was no lateral X-ray done before. The only lateral X-ray that was done after he presented at Safdarjung. And after the lateral chest X-ray was done, there were a couple of X-rays done, and then he was advised for a CT scan. So the day he presented at Safdarjung, he was taken up for an X-ray. After the X-ray, he was sent for a CT on the same day. This is the CT on the same day of presentation at Safdarjung on the 20th of May when he was referred to Safdarjung. Now this CT scan, the report was suggestive of a left pleural empyema with a thick wall enhancing hypotenuse lesion of size 50/48 millimeters in the left lower lobe, along with the fibroatlated bands in the upper and lower lobes, suggestive of a loculated pleural effusion, oblique consolidation with necrosis. Findings were reported to be suggestive of infected etiology, Curie, tuberculin. This was a CT scan which was done on the 20th of May in Safdarjung. Not in Safdarjung, it was done at outside center. It was advised by Safdarjung. Right. So now the treatment that was followed at Safdarjung Hospital. The patient was initially planned for a bronchoscopy, but I guess after the CT report that plan was cancelled. He was then taken up for a PFT test, which was suggestive of a restricted lung defect. He was taken up for pleural tap again on 2 separate occasions. Both were dry. Post the CT report, or somewhere during the treatment, I guess, he was then planned for VATS. But that was again by the end of May. However, for the next 1 month, the patient was not given a date for VATS, and he continued to be treated only with NSAIDs, mostly NSAIDs, surprisingly. Both at Hedgewar as well as at Safdarjung, he was not prescribed any antibiotics, at least not in the papers provided to me. So he then presented to us after a month of follow-up at Safdarjung, in which, as I said, planned for VATS, but not taken up for VATS because of lack of dates. So video-assisted thoracoscopic surgery, because he was being treated as a case of empyema, so that would be the next logical step to be taken. But being a government hospital, I guess the dates are not available. Now, this is the chest X-ray, which was done on the 12th of May. This would be approximately a week before the CT was done, as you were asking, sir. The lateral X-ray is also here. Now, I would request all of you to take a look at the X-ray, as well as now I'm taking over the job of the radiologist, but I love doing this. If you just take a look at these three margins. Yes. Say, as I said, he had been given, at this point of time, he was being given multiple course of antibiotics. It's 12th of May. He was referred to Safdarjung on the 20th. At this point of time, both before and after, he was on multiple course of antibiotics off and on. This is the CT scan, which I guess will be taken up for discussion later on. Dr. Tanya, I assume? Yes. Okay, this is a CT scan with which he came to me, which was done on the 20th. The description for this will be provided by Dr. Tanya later on. Right, now. Yes, the same CT scan which is done in Safdarjung, which was reported as empyema with pneumonia, with necrosis, and for after which the patient was cancelled for bronchoscopy and planned for VATS.
The echo texture was not clear whether it is a mild or fluid.
Sir, at all times, with him, there was only one single ultrasound report. Also, that was scribbled on the discharge slip of Hegdevar. It was not carrying any ultrasound reports as such. But I do have my own ultrasound report, and all of them was just mentioned minimal to mild pleural effusion. That was the report almost throughout. Almost all the ultrasounds were a photocopy of each other. None of them had a gross or a moderate effusion. They all had a mild to moderate. At max moderate, that was just once. Mostly it was mild to minimal effusion. And it was always dry. Even ultrasound guided was dry. At 4 different occasions, all dry taps. So, right, okay. So,
Is this X-ray, how long was it that?
so this X-ray is 2.5 months after the first X-ray. 2.5 months. That was on the 20th of March. This is 28th of May. So 2 months. Yes. This is 2 months hence. So I would, again, in case I had a marker, I would love to see, because to show you something else in this X-ray, but we will get to this later on. That is the most interesting part, I guess. In case any one of you sees something which he thinks is not being mentioned, I will request you to keep it to yourself. I'll give you 1 more minute to look at this X-ray once again. At the same area apart from the effusion, there is something else in this X-ray which sadly was missed by whoever reported it. So if you've all seen this, if someone wants to have a closer look, maybe, but do not ask. Pankaj sir, do not ask. Keep it to yourself. We will come to it later. So, shall we proceed? Yes, thank you. Done 8 days after the CT scan that we have discussed. The patient has had only one CT scan, so let there be no confusion about it whatsoever. Right. This is the X-ray which I got done when the patient presented to me on the 27th of June, which is a full month after the previous X-ray that we just saw. This is the X-ray a month after the previous X-ray. This is the X-ray on the 28th of May, and this is the X-ray on the 27th of June. This was the 1 month that he continued oscillating between various departments in Safdarjung, trying to get a date for VATS, which he did not get. Now, when he came to me, he, apart from the previous complaints which were progressive, he also had exertional dyspnea. And that was the reason why they came to me with 2 simple requests. हम कोई जांच नहीं करा सकते, आप प्लीज दवाई शुरू कर दो क्योंकि हमें कोई दवाई नहीं दी जाए. That was their initial. So when he came to me, apart from he had cough, he was coughing even when he was sitting outside my OPD. That's why I remember I called him up 2 patients before. He had fever, 99.6, which I mentioned in the previous slide. He had tachycardia. In addition, he also had exertional dyspnea, which was progressive for the past 7 days. And that is why they came. I suspect also because... So that history was not provided as to significant weight loss. But it is maybe, yes, he might have. But what was there was that he did not want to go anywhere else because his dyspnea was such that it was impossible for him to travel from, he lives in East Delhi, for him to travel from East Delhi to Safdarjung. The appetite had gone down significantly. With dyspnea, he was anyways finding it even difficult to sleep. So this is the X-ray with which he came to us. Again, we got an ultrasound test done, which came up with the same report, minimal effusion. We did not try a tap. Already he had a history of 4 taps and he had a phobia for needles. He घुसाते रहते निकलता कुछ है नहीं. That was that. Now, at this point of time, as I just mentioned, I also wanted to take him up for a bronchoscopy, but the patient was unwilling for any kind of investigations, just not affording. That investigations are repeated after a lot of cajoling, and they were all normal, excepting for a similar picture, leukocytosis with reactionary, most probably reactionary thrombocytosis. At this point of time, I would like to ask the audience, now that you have to start that patient on treatment, apart from the treatment, I did tell the patient that even I think, because I was treating the CT report as sacrosanct. I mean, almost all of us would do that. If you get a CT scan reported by a radiologist, you would assume that report is correct. And you would paste your treatment on it. I had my doubts for one simple reason, because of this X-ray. Now, in this X-ray, there is a very clearly defined air fluid level over here. you would see this. Now, this to me did not make sense. If I'm taking this to be a case of a infected empyema, this to me did not make sense. It did not add up with what was being reported. Yes, they had said that they had pneumonia with necrosis. However, this seemed like one continuous pathology rather than two different or separate pathologies. Something was being missed. Something was being grossly missed or underreported or overreported. So, as I said, I had the luxury and I utilized that luxury. What I did do, obviously, it's something which is, can be taken to be controversial, but that is something which I did. So, and I will be asking your views as to what you would have done. I did start the patient on ATT. Once I had the X-ray and once I knew that the patient is not going to get any further investigations done, in my point of view, this patient was a fit case for empirical ATT therapy. We had no tissue diagnosis. I'll make that clear at the very beginning. We had no sputum. We had no pleural fluid, nothing. And there was no option of getting any investigations done at all. There was no guarantee as to whether the patient would be taken up for that. He still hadn't got a date. So what I advised them was, please do continue a follow-up with Saptachan, but we will start you on ATT right now, along with broad-spectrum antibiotics under steroid care. I was, at this point of time, treating this patient as a case of a complicated empyema with organization. So that is what my treatment modality is for such patients. Antibiotics, in this case, ATT. Again, ATT because the CT scan report said the findings are suggestive of infective etiology, curid tubercular. In some cases, that is the only thing which we have to guide us in giving ATT. So I did that. And what I did next, I sent the CT scan for re-reporting. Something which some of us might have done because I thought something is being missed. So I sent the CT scan for re-reporting. The same films, I sent them for re-reporting to Dr. Tanya. And so, as I said, what we could have done next? Could I refer the patient back to government hospital and ask the patient to be patient? Treat the patient with another course of antibiotics and NSAIDs and hope for the best, like what was being done? Or treat the patient as I did empirically based on my clinical judgment? Right. Coming back to the X-ray which I was mentioning. The X-ray on the 28th, the very first X-ray. As Dr. Pankaj is pointing out, there is a very well-defined A fluid level over here as well. Could be a case of a necrotizing pneumonia with the A fluid level, yes. But this was the very first time that this particular lesion was visible. Based on this and the X-ray which we had, the CT was sent for re-reporting. And this is the re-reported CT scan. Mild left pleural effusion with collapse consolidation of underlying left lower lobe. Hypodense areas noted within the collapsed lower lobe pulmonary parenchyma, likely lung abscess. This made sense to me. That is what I was assuming at the very beginning as well, once I saw the X-rays that were done at my hospital. Based on this report, apart from the treatment that already started, I added the patient on anaerobic cover as well. On anaerobic cover. The most common causation for any abscess is anyways anaerobes. So keeping that in mind, we started anaerobes as well. I also investigated him for the usual suspects for immunodeficiency. The ones that I tested all came out to be negative. As the treatment progressed, the patient responded well to treatment. He was afebrile within the first 24 hours. The cough got reduced. He had markedly reduced dyspnea within the first week. Apart from a 2-day admission for acute gastritis, which resolved after changing of metronidazole with onidazole. There was no other event during his treatment. Now comes the follow-up chest X-rays that we had after the patient was on this empirical therapy. This was the first X-ray, which was approximately a week after he was started on treatment. This is the X-ray which was done 3 weeks after he was started on treatment. Now, questions that we need to answer. Was the physician, me, without any tissue diagnosis, correct in starting the patient on empirical ATT? At the same time, was I right on starting the patient on antimicrobial therapy without any tissue diagnosis? Does the fact that the patient has improved, just that justify my decision to start him on empirical therapy? Was I right? Or was I just plain lucky? And now that the patient has improved, do we modify any treatment or do we let the treatment continue the way it is? In which case, the plan would be to give him broad spectrum antibiotic cover for 2 months. 6 to 7 weeks is what people say is the treatment for a microbial lung abscess. And assuming it is a tubercular abscess and not having the guts to take either of the treatment courses off, continue with ATT for the remainder of the next 4 months. So total completing 2 months of broad spectrum antibiotic cover, as well as 6 months of anti-tubercular category 1 therapy. These are the questions which I am facing, and I guess I am now putting in front of the audience.
Before we take up the question, Tanya, I request Tanya to
I will get
elaborate
to-
on that CT scan.
Just coming to that, sir. Coming to that, sir, in a second. Okay. So I guess we'll let Dr. Tanya take over the CT scan first before we open the thing to the audience. Yes. CT. पहले एक CT दिखा दे एक बार. पहले points दिखाना. This is very unfit. No.
Thank you, everyone. Now, I would like to put a radiologist perspective because the question which was put to me was, is this empyema or not? And if not, then what is it? So, for our radiology point of view, in a plain radiograph, an abscess is usually, but not always, round in projection. An empyema is more of a lenticulated appearance. And an abscess, if it is peripheral, it usually forms acute angles with the chest wall, whereas an empyema would form an obtuse angle with the chest wall. So these are the ideal cases which any radiologist would have picked up. So this is a peripherally based collection which has obtuse margins with the chest wall. And here we see a fluid level and a rounded lesion which has acute angles with the chest wall, which are typical for a lung abscess. And this one would be a empyema. Whereas in CT, what a radiologist looks for to differentiate between a peripheral lung abscess versus an empyema is the relationship of the lesion to the adjacent vessels. Lung abscess, usually it will interrupt the structures, whereas an empyema, it will splay them. And one typical sign, which I think all the clinicians would also be aware of, is the split pleura sign, where we see the pleural linings enhancing in a case of empyema. The abscess has usually shaggy walls, thick and irregular, whereas an empyema usually has very smooth walls. And as I said, in what we see in a chest X-ray, same is in the CT. We see the angles with the pleura. They are usually obtuse in an empyema and it forms an acute angle in case of an abscess. And as pleural enhancement, which was the split pleura sign, an abscess usually shows good enhancement along the pleural margins. The extrapleural fat usually has haziness and standing in case of an empyema, not a lung abscess. So this is an ideal case where there's an empyema. This is splaying the vessels and the structures over here and pushing it apart. You can see the thin pleural enhancement. And this is what I mean by the split pleura sign. These are the two layers of the pleura which are split by the collection. This is seen in an empyema. And this is a typical lung abscess where we see thick walls and shaggy margins of the walls, and it is interrupting the bronchovascular structures, and it has a obtuse angle with the chest wall. This was our case. So over here, when you see the chest X-ray, This is the lenticular opacity, which would make anyone wonder that this is an empyema. But I mean, this is the film which we had, and so by underlying the X-rays which Anirudh has shown on his slide, there is a hazy density which has areas of air within it, and it has a well-defined margin as well as acute angles. Now, on the CT which we had, which I got for a re-reporting, whether it's a lung abscess or an empyema, this was the part where it was the effusion which was always causing a confusion. And this is the lesion. I'm sorry, this is the image which I had been given for re-reporting. And you can see some hazy, I mean, there is an enhancing line over here, which made me feel that it has this is a cavity, which is an abscess wall, which is enhancing. It has acute angles with the chest wall, and it is interrupting the bronchovascular markings. So this was what made me put lung abscess to be the primary reason.
Lung abscess, you can see the border clearly.
Yeah.
What's extending beyond the
That is the loculated effusion, which if we consider this thing, it's a loculated effusion. But if you consider, I'm sorry. Yeah.
Just one second. Okay.
Yeah.
So this was the big question in our minds as well, as to that if we are considering this to be a lung abscess, and it is a lung abscess, this was not just one single lesion. As you mentioned, there is another lesion, another pathology which is staring us in the face. Now, how do we account for that? The most plausible reason for that is that the patient started off as a case of a necrotizing pneumonia with a sympneumonic effusion. It's not unheard of. It's a very common occurrence. Now, as the disease progressed and he got multiple courses of antibiotics, the pneumonia initially subsided, but then because of the stop and start treatment that he was getting, the pneumonia continued to progress and convert into an abscess. What we also need to remember is that the patient had 4 different occasions of a dry tap. It is eminently possible that one of those occasions infected that pleural fluid. Sympneumonic effusions, by definition, are sterile. It is eminently possible that during one of those interventions, failed interventions, ended up infecting that sterile fluid, because mostly these effusions are exudates. And they are a very good breeding ground for any kind of infection if you tend to inoculate them with. So that is what my diagnosis was based on what we have seen till now and what I discussed with Tanya as well as some other pulmonologists too. That most probably this was a case of a pneumonia with a sympneumonic effusion. The pneumonia kept on progressing and the effusion got infected because of one of those pleural taps that were attempted.
No, sir, we don't. I mean, no. And I'd rather say this was a case which did intrigue me. That I mean, that's why we took a follow-up. What is happening in this case? That is the thing. And it is quite unfortunate for the patient, I'll think, because he has been having an effusion. And as far as radiological feature of empyema was, if we see, he didn't have a good pleural enhancement along this effusion. My request to Dr. Lochan was to get a repeat CT done, because the CT which I was reviewing was already 1 or 2 months, I mean, had already passed from this scan. But the main issue was financial constraint. This. Yeah.
And the empyema is
Yes. If it.
So sputum tiny. It was no sputum. Dry cough. Dry cough. Throughout dry cough.
When the first symptom was reported as empyema, nobody tried just for nobody tried just
So that was done on the 20th of May. And for the next 1 month after this, the patient was in follow-up with Safdarjung. And he had a couple of papers, 4 papers from Safdarjung. There was only 4 papers he had got throughout in that 1 month. One was a PST report, which was suggestive of a restrictive lung defect. which I guess was part of the investigations done prior to VATS. The second was the plan, which initially said bronchoscopy and PFT. Bronchoscopy was then cancelled. The CT reports was mentioned, and then it was referred to Department of Surgery, Pulmonology for VATS for treatment of empyema. And then after that, his entire duration was spent in trying to go between these two departments and get a date for VATS, which he never got. So that was the plan which was made in Safdarjung straight away. After the CT scan, this plan was made. 20th was the CT scan report. And I think, yes, 28th or 29th, one of these 2 days was the paper in which VATS was planned. And he was then posted for a date, which he never got for the next 1 month. Yes, 2 pleural taps were also attempted. I mentioned that. 2 taps were also attempted, Safdarjung itself. Both were dry.
From the lung abscess? If we try from the lung abscess, the aspiration of the lung abscess.
No, ma'am. When he came to us, he was, as I said, when he came to my center, he was being treated or planned to be treated as a case of empyema. And he was posted for VATS. This was at Safdarjung. When he came to us, we started, he was not willing for any investigations. He was not affording for any investigation whatsoever, including a CT scan, which now I'm not taking all this ask for a free CT scan, but that's beside the point. So, so he was only there for treatment. He had been referred to me because he was told कि हाँ इलाज शुरू हो जाएगा, and the treatment was started as empirical ATT because the CT scan report said infective etiology, cure tubercular. And for all practical purposes, when a radiologist writes cure tubercular, that's more than enough for most of us physicians. हाँ जी लिखा है ठीक है तो शुरू तो कर ही देते हैं. I mean, I don't think there's hardly a physician who would not start ATT when the patient has that X-ray that he came to me with. Sir, let me show the X-ray. Sir, let me show the X-ray first. Okay, no. I would. A second, sir. A second. I will show you the X-ray he came to me with, and then we will talk about whether or not. Sir, this is the X-ray which he came to us with. So coming to the answer that I was saying. So based on this X-ray that we had, he was started on empirical ATT and broad spectrum antibiotics, and the CT scan was sent for re-reporting. The re-report came with a lung abscess as the provisional diagnosis, as the most probable thing. And then what had been started was continued. To that was added anaerobic therapy. At the very beginning, I had a disclaimer that just because the patient has responded does not mean that I was right.
What you have done is absolutely correct. But I think we should see the last slide. Those questions should be addressed actually.
Absolutely.
Those questions are what we got to.
So, the last slide, if you have written all the questions. So, was I without any tissue diagnosis right in starting the patient on empirical ATT? You were right, but all of us are not. Reason is, when we start ATT, lot of litigation is going on. People come across lot of knowledge from different apps and knowledge that they are cross consultations. And at some point of time, what we have actually faced also, that if there is a proof started, to save the life is important. To save your skin is equally important here. So we should have probably lung abscess. If it is such a big abscess responding to ATT, I think aspiration of the abscess could have helped here.
Ma'am, we're talking about a patient.
Complementary, but
No. अरे मैम कॉम्प्लीमेंट्री की बात तो गई. What I was doing, इसकी आधी OPT patient के मैंने फ्री में करी है. वो छोड़ो. The issue is he had a fear, a huge fear of any further needles. When I say a dry tap, and if in my mind the dry taps led to that pneumonic sterile effusion getting infected, what we are looking at is not just one single dry tap. Let's not forget these were teaching hospitals. The first needle is in the hands of the junior most, and then it progresses. अरे इधर देखा मैं करता हूँ. I was in Patel chest. I know 4 needles से कम नहीं डलती अगर dry tap होता है तो. Assuming. So the patient, so that's what the patient told me. हर बार 3 बार needle घुसती है. Assumption. I already said that. That was my disclaimer.
What was clearly about empyema, because empyema, all empyema in India are tubercular.
Agreed.
Classical teaching in
Absolutely.
Yes. Empyema started it. But for lung abscess, you are not right.
Absolutely, sir. When you talk about, that is why the case is here.
You were right, but
That is why I put these questions here, because when the report came as a lung abscess, so my first Obviously, my first reaction was add anaerobic cover. That is not a no-brainer.
I think first of all, we must all congratulate you on hitting the line. And we must congratulate the radiologists on hitting. No, see, until now, until now, they were all considering a plural pathology. At least they have come forward with the parenchymal. Right? Let's congratulate both of them for getting the diagnosis of the lung cancer. Right?
There is a bug which follows, I'm sure of it. Sir, abhi
Actually, you must congratulate them where it is due. And I must congratulate them for bringing out the case and facing a barrage which I must.
Sir, let's not forget, the patient came to us, he had fever, he had tachypnea, he had tachycardia, and he was at his wit's end. Imagine a patient who is going from one corner to the other for the past 3 months. We're not talking about a patient who comes to you as the first case. No. He came to me after seeing at least 7 to 8 physicians and 2 separate hospitals. That is where.
All credit to both of you for hitting the line. Now, whether what led to what is very difficult.
Agreed.
Because the first X-ray you have shown us there's an infusion, probably it's already infected by that time. Now, that's all conjecture. But as far as the treatment goes, now whether to give antibiotics or anti-tubercular, I think that's $1 million question.
Yes.
None of us can answer. It is best left to the treating physician.
So the question which I would obviously want everyone here to answer on my behalf also, because that is something which I am questioning every time. So the thing is, okay, I give you a classic thing, dilemma, which is in my case. The patient came to me with exertional dyspnea. अब वो कांवड़ लेके आ चुका है और बड़ा खुश होकर बता रहा है सर मैं कांवड़ भी ले आया ठीक है very good. So he is thrilled with life, responding very well, no symptoms whatsoever, back to his job, earning well. He was the only earning member of his family, a sister and a mother. Everyone's happy. वो छोड़ो. For a physician, now I would always like to do the right thing. In my mind, in my heart, I want to be justified for whatever action I take. Yes, the patient's happy, good. There are times when we are right and the patient's not happy with us. So that's what is life all about. In this case, now that the patient is responding, he is well, and in my mind, it's a case of lung abscess. And in the differentials and the causative agents of lung abscess, no matter which country you might be, tuberculosis is there, yes, but it is not the most common diagnosis by no long shot. I mean, if you say कि top 5 causes में tuberculosis है, you're wrong. बहुत सारे organisms हैं जो कि cause करते हैं. Yes, he is not immunocompromised. Yes, he has no periodontal infections. Yes, he has no history of alcohol intake. Yes, he has no history of any promiscuity. All of those cases are taken care of. So we do not even have the reason why he had a lung abscess in the first case. You just do not end up having a lung abscess in a 28-year-old, physically active, non-immunocompromised male with no history of any aspirations, no history of alcohol addiction, no history of any promiscuity. But he still has one. The patient has improved. Now, do you continue with just the antibiotic therapy and stop ATT? Do you continue both the ATT and the antibiotic therapy? And then, as I mentioned, stop the antibiotics after 2 months and the ATT after 6 months? Or do you try and convince the patient to now go in again for some sort of a tissue diagnosis, now that the patient is willing to listen to us? But then, as I said, the patient is so much improved that he might not be willing for anything else now. What do we do next? I have told you what I have decided to do. Give 2 months of continued treatment for 2 months. After 2 months, stop the antibiotics. After 6 months, stop ATT. That is my plan. But people over here have more experience than me, so I would like to know what you will do. That's right, sir. No. He not first week of July. No. He came to me in the last week of July. So पहला भी चैरिटी से हुआ था. हाँ, इसी से तो हुआ था वो. 6 buildings away from the re-reporting site. So उससे 6 building आगे एक और भी है. हाँ.
You started ATT and antibiotics, and after 3 weeks, you got the X-ray done repeated. You think anti-tubercular treatment would have reduced picture like that much? No anti-tubercular treatment would improve the X-ray within 8 weeks. No anti-tubercular.
Agreed.
So how do you justify giving anti-tubercular treatment?
So first, if you're talking about rheological improvement with ATT, yes, it can happen. It's not necessary that ATT. So we're talking about a pneumonia, we're talking about a lung abscess. So there is no such thing which says कि अगर tuberculosis है तो we cannot possibly base a diagnosis कि कितने दिन में response आया. For that matter, just say if 3 weeks.
X-ray results will take place later on. Patient may improve. Symptomatically, he will improve. Fever will.
So this is the X-ray on the 31st of July.
But
and-
the picture you showed that showed almost complete resolution of the.
You added steroids also.
Yes, sir. In the beginning, yes. So this is the X-ray. So he came to us on the 27th of June. He came to us a month later, 4 weeks after that. This is the one which was taken a week later. This is a week later after the 10 days later after the ATT was started. Even in this, there is a mild resolution based compared to the previous X-ray, and this is the one a month later. We can ascribe this to either 3 agents we gave. So you say we should stop ATT? Sir, I belong to the school of thought which says you do not stop ATT if started unless until the patient has a huge. I am not planning to stop, but I would still like to know. Sir.
I think it is very easy for all of us to discuss a case which has happened in March, and the treating physician has been juggling the doctor's dilemma, breastfeeding, all the palpitations, and discuss in September and give our opinion. Please remember, in medicine, desperate situation needs desperate medicine. He was in a desperate situation. अरे यार मेरी तुम्हें बात सुनो, आप ये बोले चले जाते हैं। मैं एक्सपीरियंस सर, मैं एक्सपीरियंस व्हाट आई एम स्टडीइंग, आप मेरा फूड ऑफ थॉट तो आपने बिल्कुल ब्रेक कर chain, please don't break my chain of thought. So, and I am telling you, those who are saying stop TB, don't start TB. If they would have been in similar situation, they would have started both of things. In India, I have been taught, and I have, I think, more experience than any of you. 55 years medicine. 68 I did my MBBS. In 1974 I did my MBBS. Any patient of any lung disease who is not 1 week, 2 weeks, 3 weeks, he has come to him after 2 months here and shuffling from one doctor to another and so many other antibiotics. He was very right, irrespective of any etiology, starting ATT. He started ATT, he started both the drugs, and the second question was I right? Now, we don't, whether you are right or not, whether the patient is improving or not, that is more important. If with your treatment, what is called a therapeutic trial? In tuberculosis, we all know therapeutic trial is a rule of the thumb. So therapeutic trial was given to him and the patient improved. So I think in respectively you can say, yes, you are right in giving the treatment. But now is a $1 million question. When you start an ATT, patient has improved, it is very difficult to stop in between. Many people, you can say, I think 1 month is too early. Even an X-ray after 1 week was showing some improvement, which is very, very unlikely, as Govind said, to tuberculosis. But I said, medicine is not by 2 and 2 into 4. People know what I will respond, he may not respond, another patient may not respond. So these are the situations which put us in a fix. And that is why the case is here. Otherwise, he would have not got the patient or the case here. So I think, what was your next question? Was I right on just plain lucky? Well, it is very deep. The patient was lucky. Whether you are right or wrong, we further know. I think you are right. Was I right on starting the patient on antimicrobial therapy without any tissue diagnosis? As I said earlier, desperate situation means patient was not willing for any investigation. Patient was not willing, and he has come to my hospital. I have to save the patient. So I will do anything at my command to save the patient. That is my criteria. Medicine, evidence-based medicine and practical medicine, there is a hell of a difference. People do agree, evidence-based medicine, everything, but many a times your intuition, your experience, your clinical judgment is more important than evidence-based medicine. And here, the clinical judgment of both these people are more important than evidence-based medicine. And next, if the patient has been affording or in different patient, would any approach be different? Well, it is all hypothetical. I think you are right in starting the patient on antimicrobial therapy without anything, because it was a desperate situation. And anything else, I thought of Newton.
Yes. I was.
And that's what marriage teaches you. You should be ready for any question and every question. It's not. Although, sir, I mean, if I had to just say, because all the patients, I have had two patients of lung abscess in the recent past, taken up for bronchoscopy. In both the patients, the AFB was negative. Gene expert came out to be positive in both the patients. Yes, there is some data that you have false positives also, even in gene expert. So, but then again, once you've already done a couple of investigations with a CT scan which says a lung abscess, and with the gene expert that comes out to be positive, again, becomes very difficult for a physician not to start the patient on ATT. Sterile. That is a patient of an abscess has come to that, who's already on multiple antibiotic courses. The chances of you getting any culture positive are either way is very bleak.
I think I'm not that done available now. I think this is the case, this is scenario when you are getting the result.
Yes.
And right, every way you do whatever you want, right? You go to steroid, give antibiotic. But now in metropolitanicity, you have to justify your acts, right? So patient with a poor non-alcoholic patient, actually here give a justice to patient, and patient is still alive. So when the patient came, patient taking this thing, dying probably, maybe
Not dying, he gave me OPT, but yes, he was sick.
Good, right?
And he was markedly dyspneic, no doubt about that.
And what we have done, I said, don't do the harm to the patient. Strategy. So what justifies it? I would like to take a view on what Neeru said on litigation. Previously, it was there that any patient have a tissue diagnosis, you just report it. Now, Diksha says that you can start impeccability, writing the fact that I am writing impeccability.
There is a box for it.
Don't have a tissue diagnosis, and it can be reported as well.
And it has been reported. He has an ICSI ID too.
Right. Yeah, the patient.
Yes, that's right.
Right.
So the card is mentioned. Everything that I've written here is mentioned in the card as well. Empirical ATT, everything. Yes.
Secondly,
Yes, sir. For 2 days for gastritis.
get some improvement, right? Because with the antibiotic in a rifampicin, we are giving it non-tubercular antibiotic.
Yes.
Right. Right. So rifampicin is also good antibiotic. So I think this is all said and done, beautiful care, and this is the what we want in a forum. Right? Exactly these cases, and we should discuss where everybody is a part of it. Right? So I think this is the call that you have.
And thank you, Dr. Tanya. चल रही है PhD चल रही है
wait for 2 minutes. और 2 मिनट अभी पिक्चर बाकी में दोस्तों दोनों मिनट पिक्चर बाकी है Dr. Tirupalla, I would like to invite Dr. Tirupalla sir. Dr. Tirupalla sir, please come and present our both the speakers, Dr. Anirudh and Dr. Tanya, that they did a very wonderful job today.
Excellent.
Nicece.